Welcome to the UCSF Sports Medicine Podcast, 6 to 8 weeks, Perspectives in Medicine. During our program, we continue to cover a variety of hot topics in the sports medicine world and more.
Welcome to this week's episode of 6 to 8 Weeks. As sports medicine doctors, we are often asked, how can I lose weight to stay active? Or what should I be eating so I can stay healthy during the recovery process? These are actually not questions we are trained to know the answers to. Thankfully, there are experts, and today we are joined by Dr. Diana Thiara, who is an assistant clinical professor of medicine at UCSF. She is the medical director of the UCSF Weight Management Program, as well as the program director of the UCSF Obesity Medicine Fellowship. We cover a lot of important topics today. What are the keys to a successful diet program? How much weight loss do you need for it to make a difference? And believe it or not, it's not nearly as much as you may think. We talk about what diets work and the difference between promoting weight loss and longevity. And I think these are really interesting around the intermittent fasting craze. This is a not new, but growing trend that has taken off in part due to animal studies that show that when you restrict their diet, basically only feed them at certain points of the day, these lab mice live longer. But we find out that this may not be the ultimate in diet tools, even if it is helping promote a longer, healthier lifestyle. Finally, we talked about Wegovy, the new weight loss drug that's a GLP-1 inhibitor, and nerd out a little on how it works, who it does and does not work for, and what some of the risks of taking it are. Now, given our desire to have a jumpstart to our diet plans, it's really important to know that even with a powerful drug like this, there are no miracle shortcuts in the weight loss field. All right, Diana, thank you so much for joining us today. We're going to put this out around the holiday season, which is obviously a big time for people maybe to change their habits a little bit into November, December, and oftentimes in January and February, we reset our goals and say, now is time to diet and exercise. And I think weight loss is often oversimplified as just you need to diet and you need to exercise. Mm-hmm. It's obviously much more complicated than this. What are factors that you think should be considered when you're talking about a more personalized weight loss plan for different patients?
Yeah, that's a really important and nuanced question. I mean, I think the big picture is sustainability. So helping someone understand what they've done in the past that's worked or things that they've done in the past that haven't worked because they're so restrictive can help provide personalized recommendations. But the reality is eating and moving our bodies is so intertwined with other things, cultural, personal background, mental health, all of those things. So you really have to find out what works within someone's infrastructure, what we can push them towards changing, and what really simply wouldn't be realistic, and then come up with goals that fit that model of realism to have sustainability within their life. So I think anybody can make changes, but it's quite gradual. So making sort of small changes, really getting those under your belt before progressing to doing things that are incredibly different from your basic infrastructure, it just takes time.
So I think one of the things that I've noticed over the last 5 years, especially actually probably after COVID, is that there is a ton of information on whether it's YouTube or TikTok or Instagram on how social influencers lose weight, and they can lose weight quickly. And I still remember one of our kids came up with a TikTok video that said you can lose 500 calories in 10 minutes. And she proceeded to run around the room, do a couple push-ups, do a couple jumping jacks. And I was like, I don't know if this, like all this information is helpful or hurtful. What do you think in terms of how your job manages this with all the social media that's out there?
Yeah, it's super challenging. I mean, people can uptake social media even if they're quite low tech. Like I have a patient who can't MyChart message with me or schedule patients via MyChart, but nearly every appointment that we have to do in person because she can't use Zoom, she brings up something from Reddit or some other social media platform. And, my refrain is probably annoying, but it's always the same, which is anecdotes aren't evidence. And so what you see, it's always going to be extremes of outliers. You're going to see people who either had horrible reactions to something like a medication, or someone who had these, 0.5% type of reaction. And sort of neither is realistic and neither is what we would want for a patient. We don't want extremes on either end. Extreme amounts of weight loss is actually not healthy. You lose a lot of muscle mass and it's oftentimes not sustainable. So I think it's always expectation setting and sort of helping ground patients. And at the end of the day, people have lived their lives for so long and they know that there's no real silver bullet and these outliers are not really what they should expect. And they just need a medical provider or someone that they trust to say, that's not really how you should be thinking about things.
So I think that's a great lead in, but I think for a lot of patients, like these weight loss goals can be really daunting and it's such a big problem and it's almost harder to start just because it's such a big undertaking. And what's your advice for how people should think about their weight loss goals? Like looking at, time frames, how much to lose, role of physical activity, like how do they build that framework to then be successful in, starting to lose weight?
Yeah, I think that's a really important question. And I think the medical community is just now starting to adjust how we answer that. And, it's again, bigger picture. Our goals shouldn't, I know your world is different, but our world, we don't try and think about numbers because like you said, it is very daunting to tell a patient that they need to lose 50 pounds to have a procedure or, whatever it is. And so we know that even smaller amounts of weight loss, 5%, is when you start to see improvements in clinical outcomes. So you see improvements in blood sugar, you can start to see blood pressure come down. At 7%, you can see improvement in fatty liver disease. And these are small numbers, 5% in a 200-pound patient is only 10 pounds. So first, it's sort of giving patients these optimistic and helpful things, which is you don't have to lose huge amounts to start to feel better. And then the other thing is weight numbers are actually not that motivating. And patients oftentimes either lose interest because the goal is so big, or they reach a goal and they still feel dissatisfied, or they just, it isn't intrinsically motivating enough to keep up with the change. So we try and find these deeper motivations, either around health or, playing with your grandkids or that hike you used to want to do. Something that brings deeper intrinsic motivation will help people stick with the longer plan.
I think that's really fascinating, especially the idea that you don't need to lose all that much weight to feel a difference. And I think we've seen that, especially for hip and knee arthritis, where there's been really nice data that shows, despite all the different non-operative management options, that weight loss is the thing that makes the biggest difference in how patients feel. And it's the only thing that really has been shown to delay the need for a hip or knee replacement. That being said, there's a lot of misconceptions and myths around weight loss. What are some of the ones that have you politely banging your head against the wall when patients say, should I just do this? Or should I just eat blueberries and then I will lose 30 pounds?
Yeah, I mean, there's so many, right? Like, I think the biggest misconception is, what can I do to, quote, just jumpstart things? There's no jump starting. It's really revamping how you can do things in the long term. Also, I think there's this misconception that it's, you can cure this by just fixing X, Y, and Z that you've done wrong or been doing wrong. It sort of requires this chronic long-term intervention, but, effectively every diet, right? Like, oh, if I do intermittent fasting, then I'll reset my metabolism. And it's like, no, it doesn't work that way. Keto was a big one a while ago. I think the sort of fad diets are not as common right now, but everyone just wants to have this one intervention that will jumpstart things. And I think that's probably the most frustrating bit.
All right, I'm going to ask one more question along intermittent fasting, because I think a lot of, I would say, PhDs that have a large platform talk about intermittent fasting. One of the people we had on here before, Tom Rando, threw in at the end, like, this is what I do to stay healthy. I'm a muscle biologist. By the way, I don't eat on Saturdays. And he just kind of threw it out there in the end. I was like, wow, okay. What is the evidence on intermittent fasting? Is it good? Is it bad? Or is it good for some people?
Yeah, I mean, I think that it sort of, there's these two worlds. There's this really interesting forward-thinking idea of longevity and vitality, and then there's sort of management of chronic diseases. And unfortunately, they don't exactly overlap. And that's where intermittent fasting becomes confusing. So if you look at these super well done randomized control trials around intermittent fasting and weight loss, it's quite simple. It's actually the calorie reduction that's leading to the weight loss. There's nothing about the intermittent fasting itself that's promoting fat burning or stimulating metabolism. It's really just that for some people, if they eat fewer hours of the day, they'll lose weight. And so we talk to patients about it if they're eating for 14, 15 hours of the day. It might be helpful just to have this rigidity around a stop time, but we don't do the classic, eat for 8 and fast for 16. It's more just stop eating after 8 p.m. or something like that. The flip side is around longevity and vitality. There are really interesting animal and cellular based models that show fasting can improve, glucose insulin sensitivity, glucose processing, memory, function of cells, and all of that. We haven't seen it exactly play out in human studies yet, but for the average person, it's not necessarily harmful. And if there's some potential benefits, then fine. And it's not the type of thing where you're harming your metabolism if you do it one day and stop the next. So we try and talk to patients who are interested about what their goals are and why they're wanting to do it. And if it all sort of syncs up, then great, and we're supportive. But for the average patient, it's probably not going to be that important for their weight, at least. And the sort of key demographic that maybe shouldn't do this is someone who might have a history of an eating disorder or who has some disordered eating, because we don't want to add more rigidity or overthinking around eating in that patient population.
So one thing that we've seen a lot is, and you brought up like the keto diet, but there's always, some new trend that is on the rise and, takes over for a little while and then fades out. Is there a sustainable, effective diet that, is just easy to recommend and, easy to follow?
Yeah, I think the Mediterranean diet is the best. So if someone needs a book or guidelines, the Mediterranean diet is really great. It's a bit of a misnomer because it doesn't have to focus in Mediterranean cuisine. There's actually, most places in the world can adhere to the Mediterranean diet because many other places in the world eat a lot of things like legumes and these omega-3 fatty acid type foods, and other cultures oftentimes don't fixate as much on red meat. So the Mediterranean diet is great. The organization that came up with it is called Old Ways, and they actually have done a lot of work in thinking about anti-oppression in nutrition as well. So they have these things called heritage pyramids that look at other cultures. So they have an African heritage pyramid or an Asian heritage pyramid that helps people and providers talk about how to adapt people's traditional foods to the Mediterranean diet. So I think it's a great resource. It's been around for a very, very long time, and it really just focuses on healthy nutrition principles and is not meant to be restrictive.
Yeah. Also, it's really delicious. All I really heard was half the things that I eat. If you throw out the volume of bread I can consume at a holiday party, that's pretty much what I try to eat on a given day. One thing that's really come up in the last, I think, 6 months for us is the use of Wegovy, which is a weight loss drug that seems to be the first FDA approved drug to really combat weight loss as its primary goal. What are your thoughts on it? Who do you counsel it might be good for? are there people that, or are there concerns that you have about it?
Yeah. So Wegovy is, in this class of GLP-1s. And I'll just put it out there. GLP-1s have been around in some form since the early 2000s. So while Wegovy is new and used for obesity medicine, it's been around for 20 years and used for diabetes, which I just say to sort of relax the concerns about, well, we don't know what happens if you're on these for that long. Like, that's actually not true, because we've seen people on some form of a GLP-1 for 20 years. It's really this complicated dynamic, because it is amazing. And it's the first medication for weight loss that's shown sustainable weight loss. So, something like Qsymia in year 1 has quite similar rates of weight loss, but in year 2, there's weight regain. Whereas with Wegovy, there's no weight regain at year 2. And recent data through the SELECT trial has shown reduction in major and acute cardiovascular events for individuals with obesity who were on Wegovy for 5 years. So, like, nerding out, it's amazing and impressive. It will actually improve cardiac comorbidities. But what are the sort of hesitations? Well, the supply chain issues have made it incredibly frustrating and sad in many ways. It just exacerbates disparities that already exist in the world. And then the other concerns are, we work very hard to find these intrinsic motivators that I was talking about around health. But a lot of what we see is in the media, people who probably don't need to be on these medications using it for more aesthetics. And it really, I think, highlights this sort of societal ill that's been around since the Puritans around the value of thinness, right? And women obviously receive that messaging more intensely. And so it makes me feel, you always have to wonder, what are the sort of psychological harms when something like this comes out? But there's obviously huge benefits for people who've been struggling with their weight. And I think it's made a lot of inroads to think about obesity as a chronic disease rather than sort of a moral failure, which is how people have seen it for a long time. So it's very complicated. I think most individuals who have excess weight, who are really focusing on lifestyle change, maybe they're trying, but there's some disconnect, or, there's some overpowering thoughts in the brain, would do very well. Obviously, patients who need a life-saving procedure at UCSF, we see these patients who need transplants. Obviously, we're not going to put them through a long rigmarole before starting them. We would start them quite immediately. Someone with really high BMI who wants something like bariatric surgery, this would be a great first intervention as well. I think it's worth the conversation for most people. Who should not take it? These medications are absolutely contraindicated in pregnancy. They can increase fetal loss rate. So women who are of reproductive age really need to be counseled about that risk. And they're meant to stop the medication 2 months prior to conception. And then the only other absolute no-go is someone who has a personal or family history of medullary thyroid cancer.
And then when patients start this, it seems like it's a medication that they're going to be on indefinitely. Is there a possibility to transition off after successful weight loss, or do you see the weight just come right back for those who do stop taking it?
Yeah, so the studies around the Wegovy, semaglutide 2.4, have been very well done. So there's sort of 2 studies that we look at, which also mirror what we see in real life, which is, they put people on Wegovy, they lost all the weight that we thought they would lose. And then after 1 year of losing weight, they removed half the group from the medication. And that the group that went to placebo regained 2/3 of their body weight in 1 year. And we would expect longer term, they would regain even more. And these were people who were counseled on dietary and exercise guidance. So it wasn't people, how we sometimes see it, who were just given a prescription and sort of left to do whatever and check in every 6 months. These were people who were pretty well tucked, and they had that much weight regain. And, they did another study where they put people on Wegovy for 6 months, and then people came off to sort of test this idea of jump starting thing. And it was the same. Within 6 months to a year, people regained 2/3 of their body weight. which for people, the way they feel, that's gaining a lot of weight. But then also when we look from a science and medical perspective, they're only maintaining, around 5% of their body weight, which really is clinically meaningful, but just at that cusp. And we would expect them to gain even more. So we're not really accomplishing much from a health outcome perspective. And it's a huge cost. And the psychological toll of losing and gaining weight can be quite extreme. So don't recommend, if someone has this idea that they want to only do it for a short amount of time, we try and counsel them away from that.
Yeah, it seems dangerous for people that say, I want to lose X amount of weight just for a wedding, a photo shoot. Drew is thinking of using it for his next golf event, and it really seems that that's the worst possible use for it. You kind of touched on this earlier with the intermittent fasting. What do you actually lose if you're on one of these GLP-1 inhibitors? Is it fat? Is it muscle? Is it some combination of the both? Is it controllable based on how much you're exercising with it?
Yeah, that's like the $1 million question. So, the sort of first answer is that no matter what form of intervention someone undertakes to lose weight, they will lose muscle and fat. So if someone has bariatric surgery, if someone just goes through lifestyle change or medications, you will lose muscle. That's obviously problematic, especially in older patients. There's a lot of risk associated with excess muscle loss. So let me answer the first question. There's not been any DEXA scans that show for the medications for weight loss how that plays out and what that ratio is of fat to muscle. Simply put, we just don't know. But how do we mitigate it? There's a few ways. One is that's when rapid weight loss is really not great. If someone's losing weight really quickly, you have to assume that a lot of that is muscle. So we check in with our patients every month as they're up titrating to that effective dose to make sure they're not losing weight too quickly. And if they are, we'll either hold them at one of the lower doses or even decrease a dose. We also make sure our patients actually have an appetite. Not eating is not how we want these medications to work. So if someone's not eating, we really have to make sure that they're getting at least 1,200 calories a day. Otherwise, we talk about potentially stopping the medication. So we want to make sure they're eating enough. They're not like throwing up or having diarrhea that's making nutrients not absorbed. And then after that, the guidance is pretty steady. Good solid amounts of protein throughout the day. So protein at each meal and having it be this healthy, low saturated fat type of protein. And then engaging in strength training at least twice a week. So that can be body weight to start. And then hopefully at some point getting into some type of weighted strength training if possible as well.
And how well tolerated are these medications? We hear some about the side effects with nausea, diarrhea, but what's like the typical experience, and what do you counsel patients when they're thinking about starting one of these?
Yeah, I think that's really an interesting question, because what we see is probably what one of these pharmaceutical companies would hope for, which is patients have side effects and we counsel them through it. And if they're experiencing too many side effects, we sort of hold the dose until it gets better. So almost everyone will have some level of nausea when they first start it. And usually at each increase of dose, so it takes 5 months to reach the effective dose. Each month we go up. And usually in that first week of increasing the dose, people will have some level of nausea. Throwing up is not common, or at least not something we would continue someone on the medication. So I think when you look at social media, people say like, oh, I'm so sick, I'm throwing up. That means this is not a good medication for you. And you should probably check in with your doctor. And so if someone is really nauseous, you want to make sure you're not having super high fat meals. GLP-1s, one of the things they do is they keep food in your stomach longer. So high fat, super high protein meals are already going to be in your stomach longer, and the GLP-1 is just going to make that worse. So smaller meals, not super high fat, balanced protein, and then eating smaller meals more regularly throughout the day can usually help with some of that nausea. For the diarrhea as well, sort of making sure people are getting a lot of fiber and trying to spread out meals. But at the end of the day, there's some patients that nothing's really going to help. And you have to have conversations about, is this actually long-term sustainable, right? Like, are you having diarrhea, but it's like just loose stools once a day? Or is it, I can't go to work, I can't go to my kid's dance recital, I can't visit my parents or whatever because my diarrhea is so bad? That's not, we would say that's not something we would want. We should probably come off. I think what happens in the real world is people get a script for those 5 titration months and they sort of don't see anybody and they just go online to hear, is this normal? Is it not normal? What should I do? And that's really not how it should be done.
Yeah, that's really fascinating. This falls into the anecdote, but not evidence. I've had a couple patients that were on these who didn't heal from their surgeries. So both of these were, I would say, surgeries that they would typically heal from, and then they came in and had not healed. And the question is they had been followed for their nutrition, their albumin had been checked, but should we be doing a more sophisticated check of these patients' nutrition status, especially when they were both in that first 5-month quote unquote ramp up period? But I think the reality is we just don't have enough data to say that was anecdotes or that's early evidence.
That's so interesting. Do you see that, or have you seen that with patients with diabetes who are on a GLP-1, or has it only been in the patients with obesity on these medications?
Yeah, that's a good question. I think the problem with the diabetic patients is at baseline, as you're aware, they don't heal as well from surgeries to begin with. So we counsel them that because of that underlying diabetic condition, you are at increased risk for your rotator cuff not healing. You're not doing as well after a shoulder replacement. You may have a dislocation. So a lot of these fall into the comorbidity category. But for the 2 patients that hadn't healed, this seemed to be their primary difference compared to the other patients because they were non-diabetic. They were both taking it for a high BMI, which unfortunately also is an independent risk factor for some of these surgeries not doing well.
That's super interesting. It would be curious to check in with the bariatric surgeons who probably have the highest volume of surgical patients on these meds to see if they're noticing any similar trends. Yeah, that's interesting.
Yeah, so this was super informative. It obviously touched on a lot of things. And as we've probably figured out, this could go on for hours. We didn't even cover bariatric surgery. We didn't cover Drew's most recent fad where he only eats pretzels around holiday parties. But thank you so much for joining us. Hopefully people will find this helpful and set some trends around eating more feta cheese and a Mediterranean instead of American diet.
Thanks for having me. This was fun.
Thanks for listening to the UCSF Sports Medicine Podcast, 6 to 8 weeks, Perspectives in Medicine. What do you think of this topic? Connect with us now. In addition to finding our contact form, you'll also find our social media links and our entire 6 to 8 weeks episode archive. Help us grow our listenership by liking, subscribing, and sharing everywhere. We're eager to hear from you, and we'll be sending you more great thought-provoking content in less than 6 to 8 weeks.